Good morning, everybody. It's wonderful to be able to talk with you. I really enjoyed the yesterday and the really awesome talk this morning, which is particularly beneficial for me because it's done about 98% of the work. Patrick said to me this evening, "You have 64 slides. Is this an error?" I responded, yes it was, but actually it wasn't, but now it is because most of the work's been done. But the great thing is that hopefully you'll be able to understand a little bit more about what I'm trying to tell you, and also we reinforce some of the good things that were said in the previous talk. So I'm a clinical perfusionist, and when Patrick was doing great works in Africa 30 years ago, I was here. I was in the University Hospital in Basel doing cardiopulmonary bypass. So it's great to be back after 30 years. Okay, what do I want to talk about? Well, I want to talk about how some dead patients are managed for organ transplantation. So a particular subset of patients that and they're known as Maastricht class 3 patients. So these are patients in controlled death. Essentially, they've had a global injury which will unfortunately lead to their death, cerebral injury, but not brainstem dead. So we have to let the heart arrest. And these afford us some a special advantage with regard to trying to understand what goes on in that period. I'd like to touch upon what I call signal to noise. So basically, trying to keep as much of the brain as possible, as much as the synapses, as much as the information in the brain, and to avoid the infarcts. And to do that, thinking about time it takes to do things, the temperature which we do things, when temperature's good, when it's bad. That's already been talked about this morning. Blood and oxygen, and just perhaps drugs, but maybe not. So what I'm interested in here, or what we're as a group are interested in, is repairing the rot from non-heart-beating patients, non-heart-beating donors. So getting the best preserved organs for transplantation, and if some of it's relevant, to getting the best preserved brains for subsequent reanimation. So, and how to do this cryopreservation. Okay, so starting with the Chinese, who said everything first. Of course, they invented everything first. The only thing they didn't invent was the camera, so they could have taken photographs that proved it. But that's a philosophical point. But I'm only interested in the one step, the first step. I'm interested in the beginning before cryopreservation, and that's what I want to talk to you about, because I think it's an important prerequisite to if there's any, to get the best out of the patient and to give them the best chance. Okay. So what I'm to talk about is the time from when a patient goes into low cardiac output, which they tend to do as the heart fails, as all the systemic systems fail, and subsequent death. That's the cardiac arrest of the tissue bed and brain as well as the body, and that affects how the outcome to transplantation, which it does. And there may not be as much time as we might think, sadly. So cooling does not provide the complete answer. So what we need to think about is the correction of the damage at the agonist stage, the stage when the body's shutting down and dying, but before the actual death, and the stage known as WIT, which stands for warm ischemic time. There's going to be lots and lots of letters which won't mean anything to anybody. Sometimes they don't mean much to me, and sometimes the different letters for meaning the same things, so forgive me. That's the way that we work. So again, it's this, it's said in chronics, and it's been said to me on a number of occasions, but it's going to be, yeah, we're not so great now, we're going to be better, so first in, last out. And it's all a question of signal to noise. So, I mean, I sort of think about the idea, could I possibly have used the cell phone now to record the the talk that just occurred. Brilliant, brilliant as it was. Would have liked to do that, but of course my cell phone is not competent to do that. It's not sensitive enough. But theoretically, the molecules are still bouncing around. There's still the energy that was given to them by the talk. But assuming that the microphone was good enough, would you ever possibly find an algorithm that could suck the data from the noise of all the other molecules bouncing around in the room? Probably not. So garbage in, garbage out, that's the thing that we wish to avoid. I attended a talk by Professor Sir Martin Rees recently at Cambridge, something called Blue Sky Lecture. Brilliant, great lecture, crowded audience, loved it, everybody loved it. At one point he said, 3 Oxford Dons are going to have their heads frozen. In fact, one of these Oxford Dons has just been mentioned, but I mean, you can imagine that he said it in a way that was exploring the, going beyond possible futures into something that's completely ridiculous. And of course he got a massive response to that. Everybody loved the silliness of Oxford over Cambridge, very sensible, very clinical. Okay, so but I was thinking about Professor. I mean, clearly he's a very senior and distinguished scientist, elderly, much respected. So I thought about Clarke's 3 laws, and in 1962 he wrote that when a distinguished but elderly scientist states that something is possible, he's almost certainly right. When he states that something's impossible, he's very probably wrong. It may actually apply to me because I'm quite elderly as well. So second law, it talks about the venture into the impossible, so that's all reasonable. But the other thing that struck me as well was that any sufficiently advanced technology is indistinguishable from magic Maya talent. And the reason I say that is because the two are not the same. So my hypothesis here is that the possible is limited by the physical laws of nature. And I think that we need to work within that if we're going to have any prospects for eventual success. And there will always be a point where the signal cannot be extracted from background noise. So the better brain preservation in what we're talking about here, the better the chance that you're going to recover the patient subsequently. Technology really doesn't equal magic. Had to do something on space travel. I attended some talks and got involved with something called the Icarus project, which is looking at interstellar travel. And we were looking at propulsion devices for the sort of, in the possible future, but we also played around with other sort of more extreme concepts. And one of them was warp drive. And to everyone's great pleasure and elation, that the warp drive had moved from actually creating a warp-in space-time, which would allow the spacecraft, although in its own bubble, travelling sublight speeds would appear to be superluminal from an external perspective. And the calculation now is that it only takes the conversion of 10% of the mass of Jupiter into energy to create the warp that would compel the spacecraft. That's fuel economy. So that's possible. That's possible. Tricky, but possible. Time travel, I think we've gone beyond it. I think we're now into magic because the physics is increasingly against the idea that time travel is possible. So that's so somewhere between the two here is probably the edge. Now I'd like to talk about temperature and chemistry. Well, I mean, I sort of experiment with this stuff all the time, and it works for me. But as far as but how does it affect neuroprotection? Probably not so well. Okay, so in the 1940s, 1950s, Bigelow demonstrated that safe and cerebral ischemia would last up to 3 minutes if you did nothing. That's to say during cardiac arrest or a cessation of blood flow. But the surface cooling, if you surface cool to 30 degrees, you could get 10 minutes. 10 minutes. In the 60s and 70s, people developed, with cardiopulmonary bypass, did hypothermic circulatory arrest. And that could give us it would get down to about 18 degrees. That would extend circulatory arrest down to 30 to 60 minutes. Safe in a relative term, because there are still damage, there's still, things don't always go well, but it's safe as a relative term. So, but that's doing something such as maintaining the gradient between the perfusate and the base of the brain, nasopharyngeal pressure, temperature, less than 10 degrees Celsius. There's also the neuroprotective agents, and I'm really not going to drill into those, but just need to say that there may be others that are maybe not recognised at the moment that could have some value in other areas apart from just circular arrest in cardiac surgery. This particular graph I sort of stole from Joe Smith, an anaesthetic colleague of mine, and he put together some other works as. This thing obviously the second part missing. Yeah, okay. Maybe not. Okay, at the top far left, as you look at it, there's the top of the graph at 37, and you see these little marks, and that's essentially the beginnings of, or the limit of ischemia possible in minutes at normal temperature 37. And as you can see, it's more than 3 minutes. That's curious. It's actually sort of different work found different numbers, but nonetheless, it seems to be 8 to 12, maybe. I mean, certainly that fits with my clinical experience, anecdotally. And as you call, then that period extends. So clearly, the ground conditions for these different studies have produced different results. The reason why the graphs goes a little bit odd at 18 is because the data doesn't support the smooth curve to 10. So that tends to be functionally where we work to. But the caveat in all this is that prior to circulatory arrest, the patients would have had full cardiac outputs, not cardiac outputs themselves, but on cardiopulmonary bypass. So full support, full control, and that makes a difference. Okay, getting into the main, sort of close to the main part of the talk. One liver, as you can see by the hands, it's an enormous object, an enormous organ. Okay. So I think that this is very speculative on my part, that it could these kind of procedures could be an analogue for the cryopreserved patients. So that we've got it already in clinical practice. Why is that? Well, we've got real-world outcomes. From cadavers, we've got recovered organs, and we can tell how they're doing. An organ retrieval and recipient, these survival rates are known, but they're inferior to beating heart donors. That is to say, donors that people prefer to use. These are donors that have got brainstem death, very clear cut. We can keep the heart going right until the end, so all the organs are perfused optimally, and then recover them. Now, they're still not perfect, but they're good. And the non-heart beating donors, known as donors following cardiac or circulatory death, have inferior outcomes. But some of these donors that we're looking at are in their 70s, so they're probably in the age group that you would be tempted to cryopreservation of. So I think they have relevance in that as well. I was asked by my friend David Wood about this transplant situation with the number of donors to the number of recipients, and essentially the lag's about 2 to 1 with the number of organs recovered. There's about 3 organs per donor for the number of patients requiring transplants in. Well, this is the UK data up to 2015, which is the latest. And the donors come in three flavours, 3 colours, 3 varieties. There's the living donors, which are self-explanatory, and there's the dark blue ones, which are the DBDs, the donors following brain death. They're mainly stable in numbers, and the growing one that we're most interested now in is the donors following circulatory or cardiac death. The graft survival rates for these organs, though, is not as good. If you look at this one's shown actually, you look at the data of that particular picture, you see the attrition rate for these donors recovered from cadaver patients. Don't want to go in any further than that, but just to see that there is actually a marked difference in their quality. Another set of data showing the same kind of effects. There's, if you look, there's dozens and dozens of papers illustrating this for different reasons. So, why is this, and what am I trying to get to? Well, it could be something to do with blood flow. So this loss of blood flow, loss of that cardiac arrest stage and what it's doing, and the stage prior to the cardiac arrest. So if we look at cerebral perfusion pressures at different flows, so essentially what we've got here is somebody's running, actually this is a dog model on pump at 33 degrees. So that's sort of into what is considered to be a good area for preservation. Pump flow, as it falls, the pressure doesn't fall very much. But when you hit a certain critical point where you get a deregulation, the cerebral blood flow drops dramatically and will continue to drop. And that has a big impact on, at that point, on the oxygen delivery. It's oxygen delivery. We don't really care at the end of the day about blood pressure. We don't really care about blood flow. What we need is oxygen delivery. That's the important thing, and the gradient that allows that to happen. So,
is this with an external pump?
This was demonstrated on a dog model, and it was done on a blood pump. Yeah, so that you could actually control it mechanically. So, physiological effects of ischemia. In simple terms, nutrient oxygen supply stops, so aerobic metabolism stops. The important point here is that there's a 19 times increase in glucose to generate 1 unit of energy for the cell. So when you move into anaerobic metabolism, you burn your energy stores very quickly, you can't replenish them, and defense systems fail. That patient becomes acidotic, it's all very bad, it's not very miserable, and then you die. So you can think about it as a battery cell. You can keep the battery charged, everything's hunky-dory. If you allow discharge, you're in trouble. And in the case of, the battery dies, the light goes. I only know simple things. Okay, so anybody in kayak, where is he? Where's Patrick? Knows all about this decay curve. Essentially, the slide into as the heart fails, and so its demands for oxygen continue to increase. Demands on it increase, but the supply continues to decrease. And this goes on. I'm not going to go through all these particular variations. It's sort of fascinating. We love talking about it, but I can't talk about it here. And eventually, the worst happens, and you die. So this anaerobic metabolism ensues, and you slip very rapidly into the abyss. What was talked about this morning when it comes to intrahepatic balloon pumps and impeller devices are ways of trying to recover that. Intrahepatic balloon pumps, for instance, are situated in the descending thoracic aorta and are fired in concert with the heartbeat. It can only really support left ventricular failure, and in the world of cardiology, people often ask, what's the difference between left and right heart failure in 4 to 6 hours or anything? They're all in global heart failure. It's just that it's the left side that reveals first, and it's the one that somebody has to do something about first.
David, there's an immediate question, please.
Yeah.
Quick question. What is if the body, the tissue is somehow adapted to ketosis state, so burning ketone bodies instead of glucose, would that somehow have a protective effect here? Or is that still taking the same route?
My gut answer based on ignorance is no. But I don't know. To be honest with you, that's Yes, I can't.
Of course, I think that's an interesting field.
Yeah. It's outside my competency, I'm afraid.
That's still a very
This is a set of blood pressures that were taken from patients that would withdraw their type 3 mastocytic donors. So they're non-brain dead donors, withdrawal of ventilator, inotropic support, etc. And you wait for them to expire. And the light grey are ones that just extended on beyond 40 minutes. Another group here that faded very quickly. Some of them faded like that, and some of them faded like that. We speculate that these produce very poor organs, and maybe this one here produces better organs, based on the perfusion up until the arrest point. Okay, so one of the ways to try and fix the problem was to put these patients or parts of them on bypass, pulmonary bypass. Reservoir, blood pump, gas supply, that's the oxygenator, and for visceral organ supply. So in fact, it was done in the 1980s. The people that I know about the best are Harefield in London, who had this enormous heart lung machine. They took and had a 30-litre block of ice, which we used to perfuse patients with, and cool them down as much as possible to recover the hearts and lung block complete. Brilliant system, completely unwieldy, not used now. And in 1997, Spain led the way with the use of something called abdominal regional perfusion for these DCDs, the non-heart beating donors. They were using mostly class 2s, but class 1s, these are uncontrolled donors for subsequent recovery. And they certainly found that they got more usable organs. They improved the SIT, which stands for cold ischemic time. Primary function was improved of these kidneys, and speculated that cell depletion energy was restored, replenished, but probably not in this particular group. Those patients were cooled. So with these, there was some speculation that maybe not cooling could have an advantage. So this is normal thermic regional perfusion. This is those that we were thinking about doing, because we wanted to treat the toxic agonal and warm ischemic period. So that low pressure point before the arrest, that point beyond the arrest where nothing's happening, you're at circulatory standstill, and you're burning what energy you've got left very, very rapidly, and allow time to recover the function, a bit more careful dissection so you're not in a rush. Improved organ assessment so you can see what you've got, perhaps. Replenish those hydrogen phosphates, stop the rot, and avoid the oxygen free radical production on reperfusion. So instead of being on a battery supply, you're back on mains. That's about as simple as I can make it, I think. So, batteries, okay. Precious blood, and then we'd open up the oxygenator, and then we'd start the reperfusion. And so we'd reperfuse for 2 hours at 37 degrees. Give cold organ perfusates when we're ready. We dissected the organs out. We were looking at livers, pancreas, and kidneys, and so those were recovered then in the normal way. That's a circuit, very simple. So that's the venous side, blue, centrifugal pump, very primitive, very old-fashioned centrifugal pump. Into heat exchanger, oxygenator, and then back up. But before we start, we go. This is clamped off, and we go this way just to get everything mixed. 2 minutes is enough. Everybody wanted it to go faster, but I like to make surgeons wait. Okay, so that's our circuit again, and just a few details on what we were using. I chose Medtronic Affinity mainly because Medtronic were very flexible in what they were doing and how they could provide equipment. Biomedicus pump is a very old-fashioned centrifugal pump, but and there it is on a trolley that's even older. I love that machine, but we don't use it anymore. So that was just the trial. So okay, what's our results? three centres, Birmingham, Cambridge, Edinburgh, and did a total of donors. We finished up with 21. We got 38 kidneys, 11 livers, 3 pancreas that were retransplanted. Note here that we used patients up to 74, and that from time of withdrawal to arrest was 13 minutes on average, although between 6 and 249, so there could be quite a huge amount of variability. We would wait up to 4 hours. And then that asystole to getting on to bypass, 16 minutes. So that's from so that's getting a patient into an operating room, getting them toweled up, getting them draped, making the incision, ligating the limbs, cannulating, and on to bypass, average time 16 minutes. So that's a bit more detail. The only thing I want to sort of, sorry about this, is that essentially the base coming in when we started, even though there's only 16 minutes of arrest, minus 15, minus 20, so there's lots of, these patients were chemically deranged as well, so just to show you that they were not in a good cardiac output state for a period before we actually got there. So they were already deranged. That's the kind of the main take-home message from that, although there's lots of other data in there, clearly. Okay, so everybody got excited about this, which was the ATP ATP ratio and adenosine, and that in all cases apart from one, it fell significantly. So suggesting that these were taken with our liver biopsies at the start and the end, and this suggested strongly that we had really were recharging these patients. We really were putting the patients back on mains, recharging batteries.
David, how many more slides?
67 now. That's 67. I only showed you a little one to start with. I'm nearly there. About 4, 5. And this chaotic slide lactated the donors, and it's thought probably, so we didn't make such a big an impact, but I think it's because we were only trying to perfuse a certain section, and we were getting leaking in of lactic acid, acidosis from maybe the limbs and maybe the head. So, final observations on this using this technique. Okay, we successfully did it. Abdominal region perfusion prior to capillarization seemed to work. The reduction of the reperfusion injury in the implantation stage. So that's a pointer that doing this sort of thing does have a positive effect on the recovery side. Replenishment of ATP is beneficial. The numbers were small, but we had good outcomes, so we feel it's significant. And the speculation now is that inclusion of leukocyte filtration, that's removal of white cells, will aid graft survival, and that it represents a significant advance in DCD donors retrieval. It may be superior actually to hypothermic, so we're suggesting that actually a period of normal thermic reperfusion to recharge actually will pay benefits before cooling. And of course the legislation is evolving. I've already mentioned that. So closing thoughts that may be relevant, you can argue that it's not. Okay, the number of neuroprotective chemistries may be valued to chronics. Where and why you die is important. The why you die, the cancer, I think that's there's good ways and bad ways of dying as far as this is concerned. So
it's better to say and how, not why.
Why not? Okay. So find a chronic facility near you, if possible. Evolving legislation for recovery of organs and donors may assist chronic patient management in the future. So I think there's this thing will shift, and yes, a lot of work that can be done. So maybe chronic assisted euthanasia, which has already been discussed, and clinical management of the DCDs and non-heart beating donors on this regional perfusion may assist as the first step in the management of the patient before the preparation of cryosuspension. So prior to even starting the cryosuspension, its suggestion is that maybe there's a benefit from recharging those patients. And the maintenance of perfusion would be, we've got to take attention to oxygen supply into the tissues, adequate blood flow and pressure, that's the way you get it, as well as trying to normalise blood chemistry until controlled cooling can begin to be made and can be critical to outcomes. So it's full APT charge chemically, clean organ beds can preserve better and may improve the signal to noise ratio and the fidelity for recovery. So that's me done. This is a later type of life support machine. But anyway, thank you much for your attention.
Is the presentation maybe one or two questions? Klaus?
If cells are run out of energy totally, they are at deep rest, is it right?
Yes.
And then what brings neuroprotection?
What
brings
What use has neuroprotection?
Okay, well,
if the cells are not
okay.
reacting?
Okay, you're. This is both protection. This doesn't negate the necessity. All I'm saying is that this I perceive to be a neglected stage of cryopreservation. That chemically recharging patients, the cells, will give them the best opportunity for surviving that cryoprotection stage and that subsequent recovery. And short periods, it's surprising actually how little time has to pass before you start to see a decline in the usability. In this case, organs for transplantation, but I am speculating, I am hypothesising into the brain. Somebody can argue here, well, they're not. That's not the organs we're interested in, and the brain's completely different. But everything I know suggests that the brain tends to be more delicate, more sensitive, rather than less sensitive. So I feel that it is relevant. But it's not the same, and I think it's something that we should be, or people should be thinking about more. So I don't know if that's the kind of answer, but it doesn't mean saying you should cryoprotection is still needed, because those cells will, if you say, okay, I'll recharge them up and don't do anything, then when you go, it doesn't negate any of the necessity for them to desiccate those cells so that they can stand the cold, minimal damage from ice production, and of course you still need the low temperatures for long-term storage. So this is just the first step in the series of 1,000 steps. That's all I'm saying.
Okay.
Good. If there are no further questions, thanks again, David.
Thank you.